Well, welcome to Berkeley Town Hall on Coronavirus, Facts and Fears. My name is Michael Liu, Dean of the Berkeley School of Public Health. In the next 90 minutes, we're going to be answering your questions, giving you facts, and addressing your fears. Now, for folks on Zoom, you can ask your questions by using the Q&A feature on the bottom panel of your screen. I would also suggest watching this webinar in speaker view by changing the view in the top right corner of your screen. And for folks joining us on Facebook Live, you can ask your questions in the comment section. So before we get started, let me just introduce our extraordinary panel of Berkeley faculty. Dr. Ann Harte, Medical Director of University Health Services at UC Berkeley. Dr. Nick Jewell, Professor of Statistics and Public Health at UC Berkeley, and one of the world's top experts on statistical modeling of pandemic outbreaks. Dr. Art Reingold, Chair of Epidemiology at UC Berkeley, who has worked with the CDC and State Public Health Department on infection control for more than 4 decades. Dr. Lee Riley, Chair of Infectious Diseases and Vaccinology, and a Fellow of the American Academy of Microbiology. And Dr. John Swartzberg, former Director of the UC Berkeley-UCSF Joint Medical Program, and one of the top infectious disease experts in the field. And Bria, can you bring up the videos? All right, so many of you have submitted questions in advance, so let's get started with those. The first question goes to Nick. Nick, President Trump wants the country open up and ready to go by Easter. Do you think that's realistic?
Thanks, Michael. Sorry. Thank you very much. And that's a question of the day. There'll be a different question tomorrow. I'm going to keep my answer relatively brief, but this is probably the longest answer I'm going to give. One is that the United States introduced one of the early actions to stop the epidemic by ceasing traffic from China. That intervention, in fact, did not save any lives whatsoever. It actually was beneficial in that it bought time for the United States to prepare for the ultimate arrival of infections, which of course we've now all seen happen. That time is very valuable. Unfortunately, we weren't able to take advantage of that lead time terribly effectively. So as of today, the United States is probably the worst country of the developed world in the way it looks like the epidemic is growing. So now we're in a position with many interventions. In California, shelter in place. The question is now, can we lift those restrictions in 2 or 3 weeks? The National Academy of Medicine just posted that a 4-week intervention, even if it's effective, makes very little difference to the ultimate size of this epidemic. Even an 8-week intervention only reduces the cumulative number of infections by, let's say, 20 or 30%. So, I'm afraid that saying that we can go back to normal in Easter and have packed churches is really not realistic. The decision will have to be driven by data, and we will certainly be watching things in the next 2 or 3 weeks, but I'm very pessimistic if we lift restrictions in 2 or 3 weeks that we will not actually have done much to slow down the epidemic.
All right, thanks, Nick. The next question goes to Art. Art, can you get COVID-19 more than once?
Can you hear me okay, Michael?
Yep.
So, like a lot of questions that are really good questions, we don't have very good answers at the moment. So I think that based on a lot of what we know about other respiratory viruses, the likely answer to that is no, that once you've had it and cleared it, that you have neutralizing antibodies and are protected. But the reality is we just don't know. There have been a couple of reports of people having a negative PCR test and then a few days later having a positive test. I'm not sure that that really tells us that they became reinfected or that you can become reinfected later after clearing the infection. So I'm fairly optimistic, although Lee may have a different response, you probably will develop immunity for at least some period of time following a COVID-19 infection.
Sure, if I could say something. So if you look at the coronavirus strains that cause common cold, there doesn't seem to be any evidence that those infections will protect you against the same strains of those common cold-causing coronavirus. So if you extrapolate that to the SARS coronavirus 2, I don't know. Same thing might happen there. But yeah, Art is right that we really don't know what's going to happen. And so, yeah, we just have to wait and see.
So Lee, let me ask you a follow-up question then. Is the coronavirus something that we will be living with forever, just like the flu, and just like we're getting annual flu shots? Now will we have to get our annual coronavirus shots?
So I think there's three possible scenarios I think we're going to see with this coronavirus based on what we know about the other coronavirus types that we've seen. And so with the SARS coronavirus, the original SARS coronavirus, it went away. And one of the reasons may be that there was a reservoir, a non-human reservoir, presumably the bats via civets that people were exposed to, and there was a initial exposure, then it triggered this whole epidemic. But as long as people are not re-exposed to the same reservoir, then that may have what happened, that just kind of burned itself out. But as you know, we also have the common cold causing coronaviruses, and those are endemic. We see them throughout the year. Of course, they occur more frequently in the winter seasons, cold seasons, but we do have cold in the warmer seasons as well. And so those coronaviruses are endemic. And then there's also this MERS coronavirus, which has become endemic at least in the Middle East. And that's probably because people were constantly re-exposed to the reservoir, which is, in this case, the camels. So it really depends on whether there's a zoonotic reservoir for this virus, this new coronavirus, or that it's going to become adapted to the human population and become endemic, or it would disappear like SARS. We can't really say. We have to know a lot more about the different mechanisms and the sequences of the virus to, I think, be able to predict that.
All right, well, thank you, Lee. This next question goes to Anna. What can the general public do to help our healthcare workers and system?
So I think the most important thing anyone can do is to avoid getting infected in the first place and thereby avoid infecting others. Taking care of yourselves in all the ways that we always need to do in terms of sleep and nutrition and exercise and stress relief. Physical distancing for all of us, no matter how healthy we are, and in particular from those who may be more vulnerable. All of the same hand hygiene measures that we have been recommending for a long time. And then if people do get sick, to make sure that you're calling ahead to your healthcare provider before you go in, so that you separate those who are sick and those who are infectious from those who might be well. In addition, there's increasing calls for ways you can volunteer, whether it's blood drives or food delivery, homeless shelters, childcare, especially childcare for healthcare providers or first responders, and then not hoarding protective health supplies and other things, toilet paper, you name it, so that we can all stay healthy. There are ways now to donate supplies. So if people do have masks and hand sanitizers and various things in their basements, if you go online, you can actually look it up, and you can always call your public health department as well and find ways to donate it where it's most needed, which could be in shelters and other places, not necessarily in hospitals.
Great, thank you, Anna. This next question goes to John. Because of the severe shortage of personal protective equipment, or PPE, some people are starting to sew cotton face masks for healthcare workers. Can you comment on this? And should people be making them, or are they better than nothing at all?
I really appreciate people wanting to do anything and everything they can during this pandemic. This is probably not a good thing to do, because the cloth masks that you would make would probably give people a false sense of security. There's little evidence that they would be effective. But again, they would make people think they might be doing something for themselves, and they're not. So I would discourage that, but I'd like to see people taking their energy that they have for that and devoting it to another place. Before I go off, I wanted to make a comment about your question to Art about transmission and whether, not transmission, but whether antibodies would be protective in the future. There was one teeny study with macaques that did show that they couldn't be reinfected. I think there were 2 macaques, so it was not much of a study, but it was encouraging to see that data in non-human primates.
Great, thank you, John. And the colleges and universities have asked students to return home. Now, the questioner asks, is this a good idea given the fact that if they are asymptomatic, that they could be infecting their older parents or grandparents who are more likely to become extremely sick? Anna?
Thank you. Excellent question. I was going to say, I want to first say that at UC Berkeley, we have not asked people to go home. Just to be very clear, we've given people the chance to do so. But there are a couple of pieces to this, I think, and then I'd love to hear from others. It's a risk-benefit equation. Obviously, many college students are living in very densely populated dorms with 3 to a room. They're attending classes. They tend to socialize together, whatever the rules may be. And as such, they can get sick themselves and they can be carriers into the community. And the other thing is when they don't have symptoms, since that was included in the questions, they're much less, while they may be somewhat infectious, they're much less likely to be infectious to others. We have had a number of students calling in and asking for a test to say, I just want to make sure what I have right now is not corona. And I'll say, well, you shouldn't be going no matter what you have if you're sick, right? Whether it's on an airplane or especially home. The other piece of this is, once they are home, especially if they've left an area with sustained community transmission, which now are beginning to bubble up even in the States, but certainly internationally, we are recommending people try to quarantine or self-isolate themselves from those vulnerable people. And honestly, all of us should be avoiding spending time around anybody, especially, again, those vulnerable. I haven't been in the same room as my elderly parents for a while. And ultimately, once they are home, if they do stay well, they may be useful to support their parents too. So it's a very complicated equation.
Thank you, Anna. And John, this is a related question. For those living independently in the retirement community, how risky is it to stay in that community compared to moving in with an adult child who's working from home? John?
We know that, I said that's a tough question. We know there have been outbreaks in some retirement communities. Certainly in nursing homes, there's been some real tragedies that occurred in terms of deaths, even here in the Bay Area. Older people are at major risk for severe morbidity and mortality, much more so than much younger people. So in the scenario you're painting, if it's possible, and there are many instances where it's not, but if it's possible for an older grandparent or parent to move in with a family, and that family is social distancing meticulously, that's a good alternative. But again, it's often not possible, and so those institutions that older people are in have to be meticulous in terms of their infection control.
John, and let me ask a follow-up question from one of our listeners. Since my husband and I have been practicing social distancing and self-isolation since the 18th, which is about a week ago, I was wondering if it would be okay to visit my 96-year-old mother after 2 weeks of isolating.
Yes, with the caveat that after 2 weeks of isolating, and they really did isolate, it would be okay, given that their grandmother doesn't live in an extended care facility or nursing home. If she was living independently, for example, in an apartment, and they could go visit her without having contact with other people, that would be a reasonable thing to be able to do. But you'll notice there are a lot of steps in between.
All right, thanks, John. Art, as you know, there are a lot of kind of myths and misinformation out there. So is there any truth to the following? People with some blood types are more susceptible to virus than people with other blood types, that the virus can't survive in warm climates, that the virus won't survive under ultraviolet light, that the virus won't survive in windy areas, and that the virus can't survive in a refrigerator, for example, on a contaminated milk carton.
So I'll try my best on a couple of those. Lee Riley may be able to answer a couple of them better than I can. So there is a study from China suggesting that the COVID-19 virus perhaps is more common among people who have blood group A, or I should say people with blood group A were overrepresented among the COVID-19 patients slightly, but statistically significantly. I personally, as a blood group A individual, am not worried about that. So is there some biological explanation for why that might be true? I don't know, but blood group is associated with malaria risk and other infectious diseases. So it's plausible, but I don't think anyone who's blood group A needs to do anything different than anyone else, unless someone else in the group knows more than I do. I think, you know, the question of whether the virus, how well the virus does in warmer temperatures and in warmer climates, I think we're all waiting to see the answer to that question. But we know we have cases in 140 or 150 countries around the world. We certainly have cases in the Southern Hemisphere where it's the opposite season from ours. We have cases in tropical countries. But admittedly, we haven't seen large outbreaks yet in very hot countries. So if you look at other respiratory viruses like flu, they manage to do quite well in tropical countries, but they have a different seasonality. I don't know. Lee may know how well the other coronaviruses do in hot climates. But if the question is what's going to happen when we go into the summer here, I think we're all waiting to see, and one could speculate in either direction. I'm going to see if Lee wants to answer the question about ultraviolet and wind and things like that.
Okay, let me try. And so, you know, I think Art is right that, you know, we are beginning to see increasing number of cases in the Southern Hemisphere countries. So for instance, in Brazil is really coming up very rapidly, and they've already instituted school closings and restricting, closing restaurants and bars and restricting some work activities. And so they're getting ready. They now have, I think, over 1,000 cases with, I think, 50 some deaths. So, and the reason we have that information from Brazil is because Brazil is able to do the testing. You know, they have the infrastructure to do testing, whereas many of the other Southern Hemisphere countries, they may not have the testing. So this may be the reason we're not seeing very many cases. So it probably has nothing to do with the warm climate. To answer the question about ultraviolet light, yes, ultraviolet light will kill coronaviruses. But the wind, I don't know. I'm not sure how biologically that would happen. If keeping, I guess, the virus in refrigerators, probably will survive. It's an envelope virus, so if it's not exposed to any sort of detergents or any anti-infectives, it will probably survive in the refrigerator for a period of time. Was there anything? Was something else? I think.
Let me ask you or Art a follow-up on this. Then, what about contracting the virus from fresh produce bought at a supermarket or grocery delivered to the home? How should one handle fresh produce or groceries so as to minimize this risk?
So, I mean, there was a study that came out recently where they looked at different inanimate object surfaces. And so, for instance, the virus can survive for up to about, I guess, few hours in cardboard, but on plastic surface, it can survive up to, I think, 3 days. And then steel surface is a little less, and I think copper surface was even less. And so I don't know of any studies where they looked at fruits and vegetables and things like that. There probably is some, I would say, some duration of survival of these viruses in these surfaces. But you know, in these fruit markets and vegetable stands, they're often washed, probably with chlorinated water, and that would definitely kill the virus. But I think it's advisable that if people eat those things uncooked, that they should, you know, wash them. You know, preferably with some sort of detergent-containing fluid. But if the water is chlorinated in your house, then that should suffice.
And going back to what Dr. Harte said, washing your hands.
Right.
Right. All right. Lee, let me ask a follow-up question. And I'm pretty sure that this is on top of a lot of folks' minds. How do I minimize exposure while hiking outside? So when passing people heading in the opposite direction on a narrow trail, is there a risk of contracting the virus from the air in the part of the trail that they came from? And I guess that's a question of just how long can the droplets be suspended in the air?
So, you know, if you're outdoors, if you're on a trail, and if it's a very sunny day, the virus will probably be immediately killed by the ultraviolet light from the sunlight. And so I don't think there's really any risk. If it's a cloudy day, if it's raining, again, you know, outdoors, it's highly unlikely that the virus would be transmitted unless, you know, this person is just coughing away and you know, passing by such a person very closely, you know, I guess it's potentially possible that the virus could be transmitted. The virus in still air can remain suspended for up to about 3 hours. And so if you're in a room with still air and you walk into the room after somebody has been coughing, you know, it's possible that you can get infected from the droplets that may be suspended in air. But outdoors, I think it's highly unlikely. Maybe John may also have some comments on this as well.
John?
Speaking from somebody with blood group A like Art, I think the one study, there was a letter to the editor in the New England Journal last week that tried to recapitulate aerosolizing the particles and how long they lasted in the air. Was an interesting study, but I'm not sure it really represents what's going on in real life. I think I don't know of any evidence that people are at risk for somebody who has COVID-19 and has been in a room, and then somebody comes into the room 2 hours later after that person had left would contract COVID-19 like they would with measles and tuberculosis and chickenpox. So I think the risk is exceedingly small. You know, it's interesting for what we do in the hospitals. We consider an exposure somebody who's been within 6 feet for several minutes. Actually, currently now we're using 10 minutes. So you have to have really a substantial exposure to a person within a close proximity to really get infected.
All right, thanks, John. Nick, the press has published that the peak of the virus may not be until June or later in the US. Do you agree with this? Or do you have any studies planned that could help inform these estimates?
Yes, unchecked, without any steps to try and mitigate the spread of the virus, the models tend to show that unchecked, the peak would be towards the beginning of June. Now, there's an ironic effect of trying to flatten the curve and lower transmission, in that while that's a very good thing to do, it will make the epidemic last longer. It will push the peak out into the future, but probably not much more than by another month or so. So depending on how effective the strategies we're taking are, that will impact how much we lower the peak of the epidemic curve and how long it persists into the future. But we are looking pretty much under any mitigation strategy of peaks being out there in June or later even.
All right, thanks, Nick. Now let's take some questions from our live audience on Zoom and Facebook Live. And let me call on Priya Mehta, who's our Assistant Dean for External Affairs. Priya, are there questions from our live audience?
There are so many questions from our live audience. And I have kind of picked out 5 that relate to some of the topics that we've been chatting about in terms of social distancing and safety. Shall I read all 5, Michael, or should I read them one by one?
Sure, you can go ahead and read all 5, and we'll just kind of let the group take whichever one that they wanted to answer.
Okay, that sounds good. So here are a few questions from our online viewers. Are there any guidelines for professionals and staff who visit or care for vulnerable elderly who live alone? Should elderly and vulnerable people have their house cleaner and exercise professional wear masks and gloves while in close proximity? Please advise on best practices. Another viewer asked, can the virus be spread by my indoor-outdoor cats or from pets, from everyone walking by? If someone had the virus, coughed into their hand, pet my cat, and then I pet or snuggled my cat, could I get it? Is it okay to bring in my newspaper, which is wrapped in a plastic bag? Do I need to clean it? And if so, how? And quite a few questions around packaging and how to deal with packaging. And is 6 feet of space to avoid contracting the virus enough? In other words, can one walk side by side with a friend and maintain a distance of 6 feet? Is it really safe? The city of Berkeley has posted that no one should go hiking with anyone with whom they do not live. But is it safe to hike with non-family members if you stay 6 feet apart? And finally, question about healthcare workers. Should hospital healthcare workers maintain social distancing from family members? And one viewer is a healthcare worker who's breastfeeding an infant. What precautions should she take when she goes back to work in the hospital?
All great questions. Who wants to go first?
So let me say something about the 6 feet. My own personal view is that 6 feet is an adequate distance. And if you are maintaining that kind of a distance, even if the person you're walking with is not someone you live with, I think the reality is that person doesn't really pose a risk to you. Now we want, again, that person to cover his or her coughs and sneezes. If they're sick, they should be staying home, wearing a mask. But my own view is that the 6 feet is plenty adequate as a boundary. Maybe I'll take a stab at one more and then see what my colleagues want to say about the others. With regard to pets, dogs and cats, my own personal view is that we have first no evidence that those animals are involved in transmitting the virus to humans or that they can become infected. If the question is, if I cough into my hand and put the virus on my hand and then pet my animal, can somebody else touching the same animal get the virus that way, the same way they might from a doorknob or another surface? I think the answer is we don't know. You know, I think certainly one way you can reduce that risk is, again, by very good hand washing before and after, certainly after handling a dog or a cat. But I don't personally think dogs and cats and pets pose a particular risk to people that can't be dealt with by good hand washing.
Anyone else?
I could speak to a practical question about healthcare providers distancing from their family members, because that's come up here as well. So in an ideal world, all of us would distance from everybody all the time, physically, again, not socially necessarily, but staying away. The reality is we also have our own needs as healthcare providers to be close to our families for our own emotional health. So there's a balance in all of this. What we've been telling our staff is be meticulous about your hand hygiene before you leave work. You know, wipe down your phones, if you feel like dropping your keys in alcohol, go for it. I don't know how much that does, but change your clothes, do everything that you can when you leave the healthcare facility, in addition to protecting yourself while you're providing care with appropriate PPE. Get home, wash your hands again, don't touch the doorknobs on the way in. And then the reality is people are using the vulnerability of their family members to make the decisions about the next step of isolation. So if I had somebody living with me who was in a vulnerable group, I would be distancing myself from that person. The example of the person who's breastfeeding their baby is challenging. There's a couple of nice things, which is it seems to be less risky to children than many other viruses. So, that helps a little bit, and you need to breastfeed. So no one's recommending stopping breastfeeding that I'm aware of yet, although I'll be happy to stand corrected. But it really, really is important to just work on the hygiene when you pass from one space to another space, and to pay attention to as soon as you notice any symptoms in yourself and act appropriately.
I'll actually second what Anna was just saying. I can give a personal anecdote. And that is that my son and daughter-in-law are both physicians here in the East Bay. And they are meticulous about when they come home, they take their clothes off as soon as they get into the house, wash their hands, go in and take a shower, including washing their hair. And then they interact with their children. Now they're, of course, on the front lines, and they're getting exposed to patients with this virus. And so their children and anybody else who would be in the house would be at increased risk. One of the side effects of this virus is that we're not allowed in that house because we're at an age where the risk is substantial to both my wife and me. So social distancing is taking its toll on our family, not to be able to see our son, daughter-in-law, and our 2 granddaughters who are 10 minutes from us. There was the question about packages, and that's a difficult one. I'm of the belief that the far and away the most important way that this virus spreads is by droplets when you're within 6 feet of people. And I don't think that inanimate objects that we touch and bring to our faces are nearly as important as that. The problem is that I just said that I'm of that belief. I don't have enough science to support what I'm saying. So we have to be careful with everything conceivable at this point. It's the precautionary principle. So when people have delivered packages to our house, even though they're cardboard, and as Lee was saying earlier, that the virus doesn't seem to do well on cardboard, lives maybe up to 12 hours. And when I said live, I mean it can be found. And it may not be alive. We're bringing the cardboard in, putting it on some newspaper on the floor, or the packages in, putting it on the newspaper on the floor, washing our hands, and then getting a disinfectant and wiping off the cardboard. And then we handle it. My gut tells me this is probably overkill, but we're at that stage in the pandemic right now where we're being so careful. A quick word about the studies that we have. The studies that we have are meticulously sensitive in terms of detecting the viral RNA. What they're not telling us is if those viral particles are transmissible, because they may just be detecting the RNA and not the intact virus itself, and are not transmissible at all. So it's a caveat about a lot of those studies.
Right, and then I got a bunch of questions kind of related to this, related to soap and bleach and so forth. So one question is the body soap just as good as for washing hands, and is antibacterial soap the only hand soap good for keeping us healthy at this time? And then there's a question about bleach solution. Is the bleach solution effective for wiping down surfaces? Does it work on contact? Or by drying out. And then a kind of related question also is, at this time when it's almost impossible to get Clorox or other EPA approved wipes, are there some other kind of effective products that are not on the list? For example, 7th generation, or what else can we use and with what instruction for using. So questions about soap, questions about bleach, questions about wiping down counters, and I'll just kind of open it up to whoever wants to answer those.
I can start. So they all work. So as I mentioned, this is an envelope virus, and all envelope viruses are susceptible to soap, detergent, all those products. So we don't really need anything new.
But it doesn't need to be antibacterial soap, right? In fact, it's a virus.
Right, it's a virus. No, it does. But it's the soap. It's not necessarily the antibacterial part of the soap that's needed. It's just the soap itself. It's a it's a type of detergent, and so it will kill the virus.
I'll jump in now too. Don't buy antibacterial products. They're terrible for the environment. Dr. Riley's world authority on antimicrobial resistance, and he can give you many hours of lectures on that. So don't buy that. It doesn't do you any good at all. Soap, as Dr. Riley said, is absolutely fine. Interestingly, soap kills the virus. It doesn't just wash it off your hands, so it does both. Bleach works, except it's hard on some of the surfaces you may use it on. I wouldn't use any product that isn't EPA approved for as a disinfectant. You mentioned, Michael, 7th generation.
Mm-hmm.
There are no, I looked that up because I've never used the product. There are no studies to support the claims that the product makes that it can kill 99.9% of whatever. And there are no studies showing that it can kill the virus that causes COVID-19. So that is a product I would not use. It's not EPA approved. It causes a lot of reactions to skin, and there's absolutely no reason to use that product at all. But any EPA approved disinfectant would work fine. You also have to scrub pretty hard to make sure there's no scum left on the surface, and then that will help a lot too. If you're going to use bleach, you want to put it on and let it air dry for about 4 minutes. You don't want to just put it on and then wash it off.
And if I could just add one extra piece of advice, there's lots of misinformation on the web about this, as there is about almost everything. A lot of people trying to sell products, people talking about gargling bleach. Can I tell you that's not a good idea? And so getting your information from reputable sources like the CDC and the health department and reputable medical organizations is a really good idea. We really don't want people making themselves sick with bad advice from the internet.
And can I also add something just from a practical perspective, and also because we do studies here where we watch people washing their hands sometimes to see how good a job they're doing. A lot of people don't do a good job at all, especially kids. You really have to make sure you lather up and get it under your fingernails, especially if you have long fingernails, under your jewelry, around your thumb, places that you don't normally think about. I have a 9-year-old son, and he just tends to dash his hands under the water and think he's done, and that's not going to cut it. So, the best products on earth aren't going to work if we don't use them right.
And then there are a couple questions about kind of washing dishes and doing laundry. Do the heat and soap of dishwasher kill coronavirus? And also, what washer or dryer setting do you recommend for killing coronavirus?
Any detergent's going to kill coronavirus. So I wouldn't worry about that. And I don't think there's any setting that you need to worry about. Just in a dishwasher, the detergent and water is certainly sufficient to kill the virus.
And this is an opportunity for public health messaging. It's my understanding that most people who die as a result of the virus generally died of pneumonia. If this is the case, will one have a better chance of survival if they have the pneumonia vaccine?
So people dying from this virus aren't necessarily dying from what most people think of when they say pneumonia in the community, meaning an infection by the pneumococcal bacteria. They're mostly dying from a respiratory distress syndrome, which is an inflammatory response in your lungs. So they can die without ever having been in contact or be infected with the bacteria that's protected against in the vaccine. However, you can get secondary infections, especially if you're in a hospital setting. And the last thing you would want if you're there is to catch one. And the last thing you would want in any case is to end up in a hospital with pneumonia from a different source and then potentially be exposed. So while the pneumococcal vaccine won't protect against COVID pneumonia, it will protect you from other pneumonias, which will keep you from being in the hospital. And it's definitely a good idea for anyone who should get it, as per usual recommendations.
And Nana, do you have a similar message about the flu shot?
I do. It's still in the community. We're swabbing here, so we're still seeing flu every single week. It's not gone yet. We've had a lot of people come in assuming they have COVID. In fact, they have the flu. We're glad they came in and we treated them, and there's lots of nuances we could talk about there, but it's a really good idea still to get an influenza vaccine just because it's still circulating. And again, if you can prevent yourself from getting sick with one thing, you're less likely to catch another. Plus, it's the same people who are most vulnerable to both.
Great, thank you. And I guess I'll give this question to you also, Anna. I'm advising Three Sisters Buddhist Practice Centers. It's the San Francisco Zen Center. All our residential students have individual rooms, but share showers, bathrooms, and dining areas. Are there recommendations for preventing the spread of coronavirus in the setting?
So in any congregate living setting, it's more of a challenge to prevent infection amongst people. The same rules as always apply, meaning finding ways to distance people physically, and that might include the way you set up tables, maybe doing things in shifts so not everybody's in a space at the same time. I would definitely prioritize educating residents as to all the things that we always talk about in terms of hand hygiene and so forth, and also to make sure they know to isolate themselves in their room and inform the facility if they do become ill, so that one can arrange things like separate bathroom usage, food delivery, and other things that will take them out of common spaces. You might want to ramp up your disinfection and cleaning to doing them more frequently and making sure you have good supplies on hand, which I know is a challenge, but getting those supplies on hand is important. And then there's several really excellent CDC websites that actually specifically speak to preparing households and also disinfecting homes or community settings if somebody's sick, including advice about laundry and garbage and all kinds of other things too. So it's worth looking ahead at those now so that you can be prepared.
And there are also a couple questions about children and families. Given limited data about how COVID-19 affects children, what actions can parents of babies and toddlers, especially toddlers who are living in high density areas like San Francisco, who are just becoming more mobile and are used to being outdoors, what actions can parents take to protect their babies and toddlers?
I'll give it a shot. Treat every cold that your child has as if it could potentially be COVID. By that I mean, don't bring your child into the pediatrician if they have a cold, and don't panic about that. But it's terribly important that the child is, you're doing a lot more hand washing with the child and your own hands to make sure that there's a lack of spread. It's also really important to recognize that even as you mentioned, Michael, that children don't seem to be getting nearly as ill as adults, and particularly older adults. They still do get sick, and they still can get very sick. So certainly if your child looks very sick, you need to obviously contact your physician. One of the things that I've been seeing and talking to some of my colleagues who are pediatricians have been seeing is that children they obviously don't understand this idea of sheltering in place. And parents are often having the children socialize physically with other children. And I understand why parents are doing that, but it really defeats the purpose of protecting the rest of society, and it also defeats the purpose of keeping your child safe. So you have to, your children are just not, they're just little people, and they need to be treated accordingly. And recognize, of course, that if the children live near grandparents, that those children may represent, even though they're not sick, they could represent a way of transmitting the infection to their grandparents, where they may get very sick. Another tip that some of my pediatrician colleagues have been telling me about is don't have your children share utensils. And actually, as a caveat, the last thing was if your children are playing in the home and not getting outside very much, they're going to get pretty restless and they're going to be running around the homes a lot. And so make sure your house is pretty much as it can be, childproof for preventing injuries.
Great, thanks so much, John. Art, I'm hearing mixed messages about wearing masks. Do wearing masks protect me from getting infected when I go out?
So first of all, I think we need to provide context, which is that apparently we as a rich nation have not been able to produce enough personal protective equipment and are facing shortages. So I think the first thing to say is we're still in an environment where we want to conserve those resources for our frontline healthcare providers. And so every mask I use is one that may not be there for a nurse or a physical therapist or whatever it is. So that's the context. We absolutely want anyone who is coughing and sneezing who has to go out or go to a doctor's office or wherever to put on a mask, because we're pretty confident that the mask will reduce that person's putting droplets into the environment. I think that's very important. We want healthcare providers to wear appropriate personal protective equipment when they're interacting with patients in different settings. I think the question that is very confusing is if I'm out and about in society and I feel fine, should I be wearing a mask? And does that offer protection to other people around me? And generally in the United States, we've said no, that's not necessary. And it really is basically a false sense of security, particularly if the virus is transmitted on hands, that the mask, people are always fiddling with the masks. It increases the extent to which they put their hands to their face. And they certainly generally will not protect against aerosol particles if those are important. So we have downplayed, at least in the United States, the importance of asymptomatic people wearing masks, but I can understand why it's a confusing message. And it's a very different situation than a place like Hong Kong. When I was on a town hall type thing with people in Hong Kong a couple of weeks ago, they made it very clear to me that there it's a cultural norm that everybody should be wearing a mask all the time. It's part of the community response. We're all in this together. If you're not wearing a mask, you're seen as not being part of the team, if you will. So I think there are cultural norms that influence this, but I'd be curious if John or Anna or Lee have a different perspective on healthy people wearing masks to reduce their risk of infection.
Yeah, so certainly people in Taiwan, Hong Kong, Singapore have been wearing masks since SARS. So yeah, I guess the question is, does it really help flatten the curve?
So yeah, just growing up in Japan, it's the same thing. In Japan, even long before SARS, people were used to wearing masks just to protect against spread of common cold. And so, people either wear them if they have the cold, and then during the cold season, even if you don't have the cold, people would wear masks. So that was just a cultural thing. And, obviously that practice really hasn't flattened the curve for common cold during the winter season. So yeah, I'm not sure that would apply to COVID-19 virus.
All right, well, let's take some more questions from our live audience. Priya, any questions from Zoom or Facebook Live?
Priya asked me if I would do round two. This
Okay.
is Emily Schwartz, also working at the school. So these questions are sort of in two categories for this second round. The main one is really around timing, and the second one sort of around how we can support hospitals. So a lot of questions coming in of sort of, how do we know when the curve has been flattened? You know, what would make experts feel confident that we are sort of over the hump, so to speak, and confident about loosening social distancing and other mitigation tactics that are currently underway. Advice or sort of your thoughts about what you might suggest that we do after the immediate crisis and, before we have a vaccine, let's say in a year and a half. And also sort of when you are expecting there will be a spike in infections in the US, when you think that will occur and why it will occur then. Also when you might anticipate that we, could hit zero. There were also specific questions about sort of what's happening in our area, in the Bay Area, when we think that Alameda County, let's say, will become the most dangerous, contagious, sort of that category. And then totally in a different vein related to healthcare, there were questions, several questions about our hospitals' preparation, particularly compared to other hospitals around the world, and what steps you would recommend that people do to help alleviate the stress on our current healthcare system. So lots of timing questions, and then also around our healthcare systems.
So maybe let me ask Nick to address some of the timing questions.
Well, of course, that's, as I said at the beginning, that's the big question of the day. How long do we have to do this? And by the way, what I said earlier about an 8 weeks, maybe getting you down 20% only, that was assuming no seasonality effects. So, of course, in 8 weeks, we will be into the summer. To get it substantially down, there's an ironic trade-off here. To get it substantially down, you really need to maintain or suppress transmission for 12 or even 20 weeks before you will really make a big impact. That's a very long time for society to handle this, and I'm not able to comment on whether we can afford to do that economically. But it all depends also on how successful we are. If a significant fraction of the population doesn't really practice shelter in place, then the fact that many of us are it'll mute that impact, and it'll mean that longer interventions will be even less effective. So really the best strategy is to have a very strong intervention happen simultaneously in an entire population to try and suppress transmission of the virus. And I've forgotten now the other timing questions, if you can remind me.
Yeah,
Emily.
for sure.
Yeah.
And these are, again, just a sample of some of the ones that are coming in. But really, what would you like to see to feel confident that we might be ready to loosen some of our social distancing and other mitigation tactics? Specific questions around the Bay Area. And when you just answered that one, sorry.
Let me take that before you give me another one. Let me just take that one about when will we know that we can we've sort of on the other side of the peak and we can let up. Now in Hubei, they haven't until this week really relaxed the very stringent movement restrictions and quarantining that they did early on in the epidemic that brought infections down to close to zero, at least locally. They're just starting to do that now. The WHO on a call this morning are very concerned, as I think the Chinese are, that are starting to see evidence of a resurgence in China because of imported cases. So they've now reversed their situation, that they are experiencing a real threat of a new epidemic. I wanted to point out also that, and they've been down close to zero. So the first indication that we're having an effect in California and in the US maybe probably may come in a couple of weeks, give or take, where we'll start to see the rate of increase slow down. And will be the first indication that we're actually hitting back at the virus's ability to transmit by what we're doing. That necessarily doesn't mean the peak. It'll still go up, but going up at a lower rate to a lower peak. When you come down the other side of the peak, when you release restrictions, it's almost certain, if you do it quickly, by Easter, let's say, it's almost guaranteed you'll have a resurgence, because there's just too many people still susceptible and too many people still infectious out in the population. So it's kind of pointless at that point to ask the question unless you're willing to suffer a rebound of the intervention. I should say that the ironic twist I was going to say about a very stringent intervention to suppress transmission of the virus, we need to lower the reproductive number to less than 1, so that each infected person actually tends to infect less than one other person. That will start the epidemic to decrease. The problem with doing that now, and the problem with what the Chinese have faced, is that that's terrific. You don't end up with a very significant fraction of the population infected. The trouble is then you're just vulnerable to a rebound. And so many of the models that show how effective very stringent controls to reduce transmission are predict a resurgence of the epidemic, because as Lee and Harte said at the beginning, this is really not going to be eradicated by these measures. It's going to be endemic until or unless we get a vaccine where we can protect very high fractions of the population.
And Nick, I guess related to that, what's the basis then for what we're hearing some estimates of that 30 to 50% of the population being infected with this virus?
Yes, those estimates of what's known in technically as the attack rate, what fraction of a population at the end of the epidemic will end up having suffered infection, they're a direct product of how easily the virus is transmitted. You may have heard early on in the epidemic, coming in China, and it's really being reflected in Europe and the United States now, reproductive numbers of 2 or more, which means on average, every infected person gives birth or infects 2 or more people. That will lead to more than 50% of a population being infected, substantially more than 50% actually, with a reproductive number of 2, if there is no steps taken to control transmission. So that number of 50%, you may have heard the governor say something like that. I didn't agree with the timing. It won't happen in 8 weeks. But if the epidemic were unchecked in California, it would end up, I think, infecting more than 50% of the population. So all the measures we're doing, all the efforts that each person listening is doing right now are attempts, are individual attempts and community attempts to reduce that reproductive number as close to 1 and even lower than 1 as possible. That's the only way we can ultimately protect a significant fraction of the population from being infected.
Thank you, Nick. Anyone want to take on the healthcare questions?
I'll talk about the hospital question. Nick was talking about flattening the curve earlier. Even if we wind up with the same number of people infected, if we can get them infected at a slower rate, that will preserve our hospital facilities for taking care of people who are sick. If we have an enormous surge right away, it's going to easily exceed our capability of caring for people. And that's going to mean more people are going to die because we can't care for them. So flattening the curve, even if we wind up with the same number of people infected, is terribly important, for no other reason than to make sure that if we get sick and we need to be hospitalized, there's going to be a bed for us, and there's going to be a ventilator for us, and there are going to be doctors to be able to take care of us. In reference to the latter, whether there are going to be doctors and nurses and other wonderful healthcare providers available to take care of us, has to do with making sure we protect them. And our society has not done a very good job with assuring that. We've heard discussion about masks before, and Art was saying about the first thing to do about thinking when you wear a mask, it means a healthcare provider is not going to have one. There's a dearth of masks available, and it's not just masks. I was speaking with the hospital this morning in our community, and they're running out of gowns. They're running out of face shields. So our healthcare providers are running out of the equipment they need to remain healthy. And if they're not healthy, who's going to care for you when you get sick? So what I think we can do as a society, besides not, as Art said, not to wear masks if they're not desperate, absolutely needed, what we can do as a society is look for every way to try to support our healthcare providers in the hospitals. My wife and a lot of our friends have gone on to the Nextdoor app or other apps like that, and they're collecting N95 masks. And she's already gotten over 500 of them to drop off at the hospitals. So there's lots of, we talked earlier about making the cloth masks. We don't want to do that, but that's where other people can put energy into to support our healthcare workers.
If I could add something there too. Thank you. Yes, we need to keep us all safe. I think from a healthcare provider perspective, we're hoping that all the measures that are in place right now around social distancing and hygiene are going to slow things down long enough that maybe possibly a treatment might come along. So I'm just going to throw that out there as a question. In addition to obviously making sure our hospitals don't get overwhelmed. And I would actually love to hear back from the panelists about that too.
Great. And just on the hospital beds, let me get back to Nick. How many, based on your modeling, how many hospital beds do we are we going to need in California, and whether we have enough?
Well, we have a fair number of hospital beds currently, not particularly high in comparison to Europe because of the structure of our healthcare system per capita, but not normally a threat at all. Whether we exceed that capacity in the next few weeks or a month depends critically on whether we flatten that curve, as Anna was saying. If we don't bring it down, if these infections and subsequently some fraction, 20% of them lead to hospitalizations, and a fraction of those lead to intensive care unit treatment and ventilators. If we don't bring it down, we're going to be overwhelmed. There's no question about that. It's clear from Italy that they were overwhelmed. Now, you might argue Italy's a very small country. But at this point in an epidemic, when you've got at this point an explosive growth, but still affecting only a small fraction of the population in Italy, they have been overwhelmed, and their case fatality rate is high in part because of that, and that's a real concern of both losing healthcare workers to infection, as John mentioned, or just getting overwhelmed and not having adequate facilities, is that care for COVID-19 patients will decline. Some people will not have access to a ventilator. That will be catastrophic in those cases. And also individuals who suffer from heart attacks or other health challenges, which of course happens all the time, will not have access or will not be able to get the same kind of level of care. So the real concern is, if we don't do something and maintain it, that we will overwhelm the capacity, and that will lead to a higher fatality rate.
Thank you, Nick. We got a number of questions about testing. First one, a family member woke up with a runny nose and feeling just a little short of breath, no cough, temperature 99.8. Should he go get tested? And then another question, if I've been exposed to someone who's symptomatic but do not have symptoms myself, do I meet the criteria for getting tested? So Anna, John, who should get tested?
Anna's on mute.
Anna, you're on mute.
On mute. I'm not on mute anymore. Okay. It's my alert that keeps going off, so I'm trying to keep it from bothering everybody. So I was saying, in an ideal world, we would test many more people than we're currently testing. We would have had access to those tests months ago. We would be testing anybody who fit the symptoms, and probably by now we'd have a much clearer sense of what those symptoms are in a full spectrum of people. Unfortunately, we don't have access to that testing in the United States, and certainly not locally. And so, a lot of the recommendations we have around testing are based on the fact that there are a limited number of tests available, and that we need to preserve access to those tests for those who really need it, like the hospitals who are struggling to get testing on people who are really sick. So I just have to first say that. So to answer the question about somebody who has mild symptoms or somebody who has been in contact, we are absolutely not here right now testing people who have no symptoms, even if they have no contact, in part because of the access. And then I'll also say, and I'm sure others can speak to this, it's not really clear how good the test is anyway in people who don't have symptoms. We don't have a really good sense for how sensitive it would be and how reassuring it would be if it was negative. Currently, we here locally at UHS and most of the local community providers and even inside the hospitals are working very much in alignment with California State Department of Health guidelines, and are really reserving testing for places and people where it is helpful, either in terms of deciding how to take care of them or how to take care of others they may be around. So people who are hospitalized or seriously ill, people who are in vulnerable populations themselves, meaning either older or with significant underlying medical conditions, or people who are either in a community setting or a residential setting where they're around lots of those, such as a nursing home or a long-term care facility, or are healthcare providers or first responders who are likely to expose others if they themselves are sick. So, that's a long, complicated list, which is why all of the testing centers out there having you go through a screening algorithm to sort that out. That's probably going to change with time if local access to testing does increase.
Great, thanks, Anna. And by the way, are there drive-through or other accessible testing sites near us? Can I look up drive-through test locations by zip code?
I'm going to answer the last part first, which is I haven't found that. I was noodling around looking. Somebody needs to do that, some enterprising person out there, and I'm sure they will. You can Google and find all kinds of things, and it is changing daily. There are a number of places locally now that are doing either walk-through or drive-through testing, either through the big outpatient clinics like through Sutter, Kaiser, Carbon Health. We are doing it here at University Health Services for the students. And then there's a number of partnerships developing, such as the Verily Google affiliate through different companies that are doing online screening with access to testing. I just heard about Hayward Fire down in San Mateo, who are doing testing for first responders. And then a bunch of the UC campuses are working together to expand access to testing as well. So for right now, yes, there are some places to go so that you avoid the ER, which is the last place you should go for testing right now, to preserve their capacity to take care of sicker people and honestly to avoid getting exposed yourself.
Great, thank you, Anna. Lee, I know there's seems to be some controversy around mass testing. There appears to be two perspectives. One is that a person should only be tested if the person experiencing symptoms, but the other is that everyone should be tested and only those who test positive should be in the 14-day quarantine. Which would you prefer and why?
Yeah, so I would echo what Anna was just saying, that right now, at least in the US, we just don't have the facilities to test large numbers of people. And so really the test should be limited to those vulnerable people that was just mentioned. In Korea, they were able to test a lot of people. In fact, they had drive-through testing services all over the place. and they were able to give results within 2 hours of collecting the samples. We just don't have that kind of infrastructure in the US. You know, Korea, because of the MERS epidemic they had a few years ago, they really geared up their public health services and testing services and trained all the personnel to be able to do this kind of testing. So here, you know, we just don't have that kind of manpower. So testing, you know, mass testing requires not just the kits, which, you know, we still don't have adequate amount, but manpower. You know, somebody has to collect the samples and then process them, extract the nucleic acid, and then put them into these apparatus for the PCR. And we just don't have enough of those people here. So, you know, it will take many, many months to really have that kind of manpower to be able to do this. And what Korea did was, and also China, they tested the symptomatic people, but what they also did was when somebody was positive, then they immediately did what's called a contact tracing. So they would contact all of the asymptomatic contacts and then quarantine them as well. They didn't go about testing these asymptomatic contacts. They just knew that regardless of whether they were truly exposed or not, they just quarantined them. And that kind of approach worked because they were able to test the symptomatic ones very quickly. But here, we can't even test all the symptomatic ones. We just don't have the resources.
And let me pull Art and Nick into this conversation just about testing.
Well, I don't disagree with anything Lee has said, but what he's saying is it reflects an enormous failure of our ability to prepare for this despite a few months lead time. And that's a great tragedy that will be studied for years to come when people analyze the US response. Ideally, I think we would have preferred to have had significantly more testing capacity to detect people who have the virus and for which the test might show a positive result for exactly the reasons that Korea did that and Lee pointed out. Then you can quarantine that individual, and more importantly, you can quarantine their asymptomatic contact, all of them, which is what they did in Korea, and that clearly had a major impact. I should point out that in addition to our failure to have that capability, and I take Lee's word for it, that it's going to be months before, not days, but months before we could really do that. South Korea also, their contact tracing was incredibly sophisticated. They were using mobile phone information, they were using ATM information, they were using where you used your credit card, they were using closed circuit TV to track down a contact. Who was the person that you might say, I'm positive I bumped into someone at the bank. They would go to the closed circuit TV and identify that person. Now, with privacy laws in the US and in other Western countries, it's not clear we could do that kind of contact tracing, but I think there are some things we have to be creative about how to get around this with voluntary participation, because it's unconscionable that in the middle of the greatest epidemic in any of our lifetime, we don't have the ability to either test who's out there who's infected or test who has been infected and recovered through a serological test. That's normally the first thing we do in epidemiology is go out there and sample the population and find out who is infected, who has been infected in the past and is now immune, because that's enormously important for us being able to control the epidemic. And right now, epidemiologists in California, in the UK, in the US, are working with 1.5 arms tied behind our back because we don't have that information. I don't want to belabor it, but it's, you know, we have to try and do the best we can with what we've got, but we haven't got enough.
And if I could just make 2 additional comments. One, Nick referred to serologic testing to determine who's already been infected. Certainly those tests are becoming available, and those will be valuable tools as epidemiologists try and figure out, you know, various aspects of this epidemic. But they're really more epidemiologic tools than clinically useful tools. The other thing I'd point out is that the amount of contact tracing that countries like Korea did really require an immense amount of personnel and person time. And we are all suffering from the fact that for many years we've been underfunding local and state health departments. So they really, even pulling in all of their people who normally work on STDs or TB or hepatitis or other things, are just struggling under an enormous weight of work, even without trying to do that extensive contact tracing.
And we do have a series of questions about treatment and about vaccines. John, what are the prospects of other existing medications to stem the tide of this virus in the next 60 to 90 days versus new therapies that will require more than a year to determine the benefits and the efficacy of their use?
Sure. Well, I don't have a crystal ball, but I can say that there's a tremendous amount of energy now being placed into therapeutics. I counted yesterday over a dozen studies that have just begun or will be beginning very quickly. And there are probably many more to follow that. A word of caution about therapeutics is that, I'm going back to the early years of the AIDS epidemic, when there was, every day we heard about a new drug to treat HIV infection, and the next week or 2 weeks we discovered that it just wasn't any good in spite of all the enthusiasm and all the press they got. And I think we're seeing the same thing now. We saw that with the executive branch of our government, where the president was touting the benefits of chloroquine or hydroxychloroquine without any science to support the statement at all. And all that succeeded in doing is, well, one person died from an overdose of it, and a lot of people who need those drugs for their rheumatologic problems are now having trouble getting them because other people have been hoarding them. So we need to study these ideas we have carefully to make sure they're going to work. There was a lot of enthusiasm for two HIV-related drugs, leponavir and ritonavir, and very quickly, very rapidly, a reasonably controlled study was done to show that the two drugs were no better than not treating people. So we've got a lot of drugs in the pipeline. We've got a lot of drugs we're starting to test right now, and fingers are really crossed that some of these are going to come through, and that would really help. It's not going to save us from this pandemic, but it would dramatically help reduce morbidity and mortality. And it could conceivably, if the drugs were sufficiently safe, help prevent spread by using the drugs prophylactically. Your other question was about vaccines, and it's conceivable that we could have a vaccine in 12 months from now, 14 months, 18 months from now. It's conceivable. We still don't know what correlates with protection, so it's hard for me I mean, we really don't know exactly what we're doing with these vaccines. There's some very novel and creative ways that we're creating vaccines for trial. One trial is just starting, and another trial is going to be starting in a couple of weeks, I think, with the potential to really work. But again, the fruits of those things are going to, we're looking at, as I said, at least a year from now, and that's being very optimistic. It would also, if something came out 18 months from now, it would be faster than we've developed and utilized any vaccine in our history.
Yeah, and that's what I've been hearing in terms of 12 to 18 months. Art, why does it take so long?
Well, first of all, again, it's all relative. As people who know anything about vaccines will know, in the old days, it typically took 10 to 15 years to develop a new vaccine product and do sufficient tests in different phases of studies to prove that it was safe and effective before the FDA would license it. Now, in more modern times with modern technology, people have certainly produced candidate vaccines for Zika virus, for example, for certain flu strains, much more quickly than that. And the technology is vastly better than it was before. And if we get to a point of having something we need to mass produce and potentially have hundreds of millions of doses, that technology is much, much better than it was before. But fundamentally, John referred to the fact, I don't think we know yet which immune response is likely to be protective. That requires study and we need extensive testing in humans to make sure that any candidate vaccine is at least immunogenic, making an immune response we think will be protective, and very critically that it's safe. I know some people are already hesitant about vaccines and vaccine safety. We actually pay a lot of attention to safety of candidate vaccines before we start giving them to large numbers of people. And I don't think anybody would be in favor of starting to give enormous numbers of people a coronavirus vaccine until we were pretty confident that it was going to be safe.
Thank you. Let me go to some questions from our live audience or comments. Priya, what are you seeing on Zoom or Facebook Live?
Yeah, so we've got 275 questions on Zoom and probably hundreds more on Facebook Live, so we certainly won't get to all of them, but I've very cleverly grouped 10 questions into one. So there are quite a few questions about symptoms. Folks have heard that COVID-19 comes on with a high fever and a dry cough, but now they're starting to hear that it's a slow burn onset with fatigue and body aches. Can you address common onset symptoms? Is fever always present? What's the normal time span between first symptoms and developing fever and respiratory problems? What body temperature is considered a trigger to seek urgent care? And does that change for individuals over 65 or those with diabetes? And are you seeing any patients with predominantly GI symptoms, pain, cramp, bloating, diarrhea, and virtually no respiratory symptoms? John or Anna, do you want to take that one? And maybe I'll ask the rest after we address that.
I think John should take it.
Okay, I'll start, but I'd love the other panelists to chime in. The classic symptoms, as you were describing, Priya, are fever, body aches, cough. Sounds a lot like influenza, doesn't it? The cough typically is dry, not productive, not bringing up a lot of stuff. That's classic. That said, like any infectious disease, most of the time diseases don't present in the classic way. The question about the onset is very interesting. From the time of exposure to the time you get sick, what we call the incubation period, on average is just a touch over 5 days, 5.1 or 5.2 days. The range can be anywhere from 2 to 14 days, but the average is about 5 days. And that's when you can get sick. And you may get sick with a slow onset, as Priya was alluding to. You could develop even upper respiratory symptoms, sore throat, runny nose, looking very much like a cold. And then it can slowly progress into lower respiratory tract symptoms, the cough, the dry cough I was talking about. And then the fever can come on. Interestingly, in the early, I mean like a month ago, with cases of this disease, looking at primarily the data out of China, we saw that the time from when people got sick to the time they got into the hospital, there was often about a week's period of time. That is, somebody got sick and they waited about a week before they were sick enough to be in the hospital. So for a lot of people, the onset is more insidious in terms of they're sick, but not that sick. And then on around day 7, maybe closer to day 9, somewhere in that range, they get really sick and wind up getting very short of breath. The things to look for in terms of real concerns have to do with the shortness of breath. If you've got fever and a cough, but able to stay at home, you should stay at home. But if you're starting to get short of breath, that's when you need to contact a healthcare provider and get advice as to how to proceed. We need to know how short of breath you are. My son sent me an interesting article that was very preliminary today, talking about how long you can hold your breath in terms of correlates for what your oxygen saturation should be. we need to determine if that's accurate or not before we start using that as a clinical parameter. So I think what people should do is if they feel short of breath, they should talk to their healthcare provider. They may need to be checked out, and if they're not getting enough oxygen into their bloodstream, they're going to need to be in the hospital.
Thank you, John. Priya, maybe one last question.
I think Anna wanted to add something.
Oh, go ahead, Anna.
I just wanted to quickly say that that's the reason, that's exactly why anyone who has any symptoms should assume that they might be infectious with something. Given that we can't diagnose anything, we'd all love to know what we have, but the reality is it's probably not going to change because there's no treatment for us, but it will change how we spend time around others. And so anyone with any symptoms may have this, or they may have another virus, and in either case, they should be self-isolating and washing their hands.
All right, I think given that we got about 5 minutes left and still about 300 questions to answer, maybe we need to organize a part 2 of this town hall. But before we wrap up, I'm just going to give each of you 30 seconds to give the audience a takeaway message. We can start with you, Anna.
I think I just did. Take good care of yourselves, stay physically away from others, and if you do get sick, please call, don't just walk into a healthcare facility so that we can guide the best care.
John?
Invest in public health. As I think Art and Nick were alluding to, for decades we've been underinvesting in this, and now we're seeing the consequences.
Lee?
Yeah, no, that's exactly what I was going to say, that this is a wake-up call for all of us. And we're really seeing what happens when we don't invest in public health. And so this is something that everybody should be thinking about. And this is going to come back again and again. Are we going to do this all over again every time another, coronavirus 2, 3, or 4 comes back? This is really a serious issue, and public health really needs to be totally revamped in this country. And not just this country, other countries as well.
Art?
Well, that's the problem with going last, is Lee and John have stolen my thunder. But other than saying emphatically that we do need a lasting commitment to public health at the state and local and federal level, I guess I'd suggest that when you see a public health worker, thank him or her or them for all the incredible work they're doing.
And Michael, we actually have a last thought from our Vice Mayor of Berkeley, Sophie Hahn. Would it be okay if I read that out loud?
Sure.
Yes, please.
Please respect the orders and directives of the City of Berkeley. I hear folks hopeful about workarounds. I urge everyone to follow both the letter and the spirit of the directives. Berkeley, Alameda County, and the Bay Area have extremely competent public health officials who are consulting with other regional experts as well. We are tapping the best science and statistics. The decisions being made are for everyone's health. We recognize how difficult these orders are for residents and appreciate your compliance. Please read here for the latest official City of Berkeley COVID-19 orders and resources, and I will share that, that link with everyone.
Yeah, and let me just add my kudos and thank you to all the public health professionals, all the healthcare workers out there, and everybody on the front line out there who are really trying to do their best right now in terms of protecting and promoting the health and well-being of our entire communities. Nick, I'm going to give you the last word.
Well, I was going to add to the message just read: stay at home, do as you're told, break the chain of transmission. The sooner we do it, the less people will suffer, the less people will die. We're all in this together. And give a virtual hug to every healthcare worker in the state, because they are angels and we need them desperately now, and we love them. Let them know that somehow. Support your elders, support your community by contacting people, stay in touch. Even though we can't be physically together, we can support each other.
Thank you, Nick. And my takeaway message is the same, that this pandemic is really a wake-up call to our nation, and to our world, just in terms of how underinvested we are in public health. And so when we recover from all of this, and we will, I think it's time for the world to come together to invest in a strong public health workforce and to build a strong global public health system for the future. So please join me in thanking our panelists, Dr. Ann Harte, Dr. Nick Jewell, Dr. Lee Riley, Dr. Art Reingold, and Dr. John Swartzberg. I'm Michael Liu. Thank you all so much for joining us today. And please join us again for our next Berkeley Town Hall as we continue to bring you the most accurate, the most up-to-date information on the coronavirus pandemic. Bye-bye, everyone, and see you next time.
Thank you.